Kara Arsham. She's one of our just recently graduated fellows from last year. She had given this lecture as part of her fellowship lecture series or her assigned lecture. And she's back to give it again this year as an attendee. So, Kara, go ahead and take it away.
All right, thank you. I'm so pleased to be able to come back and chat some more about two of my favorite things, rehab and palliative medicine. I did rework this lecture a little bit to include a bit more of what I'm doing now. So I guess kind of like as my objectives and disclosures, no disclosures. I am currently working in Flint with the McLaren Medical Group. I am a physiatrist, so physical medicine and rehab is my primary specialty. As Dr. Phillips mentioned, I did the fellowship in hospice and palliative medicine last year. And hopefully by the end of this lecture, you'll say, oh, that totally makes sense. I get it. Because you might be thinking, how does rehab and palliative, how do those two things go together? That doesn't make sense. It does, I promise. And by the end of this, I hopefully will see a little bit more of that. But in my role right now, I am on the inpatient side of things. I do all of our initial consults. We get consulted on all of the stroke alerts that come into the hospital, and we are a comprehensive stroke center. So we see a wide variety in neurologic deficits from neurologic injuries such as stroke. I do see quite a bit of neuro-oncology as well because we have Carmanos right across the street, and I see a lot of medical debility as well. So palliative and rehab, I think, go really well together. Physical medicine and rehab physicians do a lot of what we call primary palliative, and we'll get into some of this as we go along, okay? All right, so we're going to start with some of the things we already know, lay that foundation, and then kind of build on that with how does rehab relate to that. So palliative medicine as part of our care team. A lot of these definitions are going to come from College of Surgeons and Commission on Cancer, American Cancer Network, etc. Palliative care referring to patient and family-centered care, optimizing quality of life. When we ask people, what is palliative care? A lot of us will say that it's about helping manage symptoms to maximize and optimize quality of life. There's lots of different types of palliative care services and where palliative care is delivered to patients and their loved ones. So as we know, palliative care medicine, we do a really great job at integrating a team-based approach because it takes a team to really deliver that excellent patient-centered care, facilitating communication between the medical teams, patients, and their loved ones to help them understand and navigate complex hospitalizations. And then on the outpatient side, helping manage and navigate living with a life-limiting illness. So, palliative and rehab medicine. This is a great quote from our Dame Cicely Saunders. The work of all the professional team is to enable the dying person to live until they die at their own maximal potential, performing to the limit of their physical and mental capacity with control and independence whenever possible. So that to me, that that quote right there is like, see, palliative and rehab, they go together like peanut butter and jelly. So again, this kind of screenshot here again goes into synergies between cancer rehab specifically and palliative care, and how the discipline of palliative care, the goal is management of symptoms that come with these certain pathophysiology. It's been shown to help improve symptoms and quality of life for patients undergoing cancer treatment and cancer survivorship. And cancer rehab focuses on functional limitations that may have come about through the course of a cancer diagnosis, treatment, and survivorship. So those two things together, function and quality of life. So let's talk about survivorship. So the term cancer survivor refers to patients who have been diagnosed with cancer, regardless of where they are at in the course of their disease. They also acknowledge that the impact a cancer diagnosis has not only on the patient, but their immediate loved ones, family members, friends, and caregivers. So, why is this kind of more of an up and coming area of interest in both the fields of palliative and rehab medicine? It's because of survivorship. This We're identifying cancers earlier, we are developing more targeted treatments, people are surviving a cancer diagnosis. More patients with cancer are living beyond the 5 year survival mark. And as of January 2022, there were an estimated 18.1 million cancer survivors in the US. So, how do we continue to help care for these patients with any deficits that have come about because of their cancer burden itself, like solid tumors or fatigue from oncologic cancers and treatment effects? Different chemotherapies are more likely to cause peripheral neuropathies that can be very debilitating. Radiation treatment can cause fibrosis of the muscles and connective tissues. So, how do we address those functional limitations that may come about in the course of treating cancer or from the cancer itself? Now, there's a bunch of guidelines, and I did include a lot of these kind of screenshots of guidelines. I'm not going to go through and read every bullet point, but I wanted to have them here in the presentation as a reference if anyone was so inclined to look them up later. I know this is going to be posted on the YouTube and then my references at the back. So just as points of saying there are guidelines, there are groups of people within the different cancer networks looking at how do both palliative medicine professionals and rehab medicine professionals, how does that help our cancer patient population, and what are guidelines for helping patients get to those services? So again, how can we help patients bridge the gap between their illness and wellness, maximizing their quality of life, maximizing their function? So, several different cancer societies recommend that patients have access to both palliative care services and cancer rehabilitation. I also wanted to include survivorship in stroke. So, stroke mortality has declined in the past few decades, which is fantastic. We've had nationwide initiatives for public education on identifying possible symptoms of a stroke, and then a Get with the Guidelines initiative to help hospital systems deliver excellent care for stroke patients. So, with the increased number of people surviving a stroke, that also means we have more people surviving with impairments and disabilities from their stroke. So, vast majority of these patients have some degree of hemiparesis, so that's weakness on one side of the body from a stroke. About a third are requiring assistance with ambulation. This could be assistance from another person or assistance from an assistive device, such as a cane, a walker, or wheelchair. 26% were dependent for ADLs. Those are activities of daily living, things like feeding yourself, grooming, like brushing your teeth and washing your face, brushing your hair, bathing, dressing, and toileting tasks, being able to clean up after yourself, personal hygiene, and those transfers required in order to be able to do those ADLs. 19% of patients will have some degree of aphasia. So that is either difficulty understanding words that your brain is receiving or difficulty getting your words out. 35% have depressive symptoms after a stroke. Not unsurprising. You've just undergone a major life-changing event. And 26% live in a nursing facility or need assisted living. So again, kind of these functional limitations and what's that impact on quality of life. A little bit about stroke recovery. The most amount of motor recovery that we see after stroke occurs within the first 3 months. That doesn't mean that it can't continue, but that's where we like to maximize the potential for recovery is in those first 3 months after a stroke. There's a couple of different points here just about prognosis. What kind of movement am I looking for right after a stroke to help guide patients who have questions of, am I going to get better? How much better am I going to get? What is life going to look like? So this is just a little bit of extra information here. It's probably more relevant for some of our rehab colleagues, but I wanted to include it here as well. So this is from the American Stroke Association on why rehab is important. So a stroke is one of our 13 rehab diagnoses for inpatient rehabilitation services. So stroke, those should be what I call a slam dunk inpatient rehab candidate. However, insurance companies are more and more becoming more difficult in me being able to recommend inpatient rehab for patients. But I included their recommendation here. Doing rehab is important after a stroke. I'll skip this one. But again, it just talks about inpatient rehab facilities and providing that level of care from a physiatrist, so that's physical medicine and a rehab physician, as well as our team, which I will get into our team members. Here's another slide on different levels of rehab or care. So inpatient rehab facilities are within hospitals or standalone hospitals. That is inpatient rehab, 3 hours of therapy a day, at least 5 days a week. Skilled nursing facilities can deliver what we call subacute rehab. That's an hour and a half of therapies a day, at least 3 days a week. But patients stay at the facilities so they have 24/7 assist available from staff. There's long-term care, outpatient clinics, and home health as well. So is rehab just exercise? No, of course not. We do so much more than just exercise. Rehab is often equated with that. When you think of rehab, you think, okay, alcohol and drugs? No, 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 not that kind of rehab. And if you're not thinking that kind of rehab, you're thinking, oh, okay, so like after a knee replacement, I go to the gym and work on my range of motion and strength. And while that is part of rehab, neuro rehab also helps address things like fatigue, bowel and bladder dysfunction, sexual dysfunction, lymphedema, pain, cognitive deficits, endurance, and quite a bit more, like neuropathic pain. Surgical site care. So we're not just exercise, and rehab is not just a disposition service, but we are still going to talk about exercise. And please stop me if you guys have questions. I'll be happy to elaborate. So rehab medicine is part of the care team. So this is coming from Commission on Cancer. I'll read this here. Rehab care is patient-centered care that optimizes patient functional status and quality of life through preventative, restorative, supportive, and palliative interventions. The availability of rehab care services is an essential component of comprehensive cancer care, beginning at the time of diagnosis and being continuously available throughout treatment, surveillance, and when applicable, through end of life. I'm hoping we're starting to see some of the overlap here. All right, a little bit more about rehab services. Screening and diagnosis of physical dysfunction, impairments, and disabilities. Interventions to manage functional impairments and disabilities. Screening, diagnosis, and management of pain and non-pain symptoms of cognitive function, lymphedema management, and hopefully sometime this year you guys will also get a lecture from a colleague and mentor of mine, Dr. Naomi Kaplan, who works with Mary Freebed and specializes in lymphedema management for cancer patients. Wonderful lecture. I hope you guys will look forward to that one. As well as talking about recommendations during and after treatment. I've got some great slides at the end of the presentation here for you guys as well. And then vocational rehab. All right, this is kind of a busy slide, but it's professionals associated with rehab. And if we look around the wheel here, we've got our medical management, nursing care, physiotherapy, orthotics and prosthetics, occupational therapy, speech therapy, nutrition management, pharmacists, psychology, social work, podiatry. It's in that interdisciplinary team approach to patient care that I think both rehab physicians and palliative physicians do so well. We know that it takes a team to deliver excellent care. So the goal is to optimize outcomes and reduce disability in survivors through early identification and treatment of cancer-related physical impairments, functional limitations, and life participation restrictions. Sometimes this last little bit here, life participation restrictions, sometimes it's about accommodating and adjusting the environment to help a patient connect with their environment, not their physical disability itself. Sometimes it's the environment that creates the handicap. So something to keep in mind as well. All right, so let's talk about the team. Physical therapy. So physical therapists aim to optimize function of our musculoskeletal, neurologic, and cardiorespiratory symptoms. They have lots of different modalities and interventions. And yes, we do exercise. But there are also specialized areas of physical therapy, such as neuro rehab, spinal cord injury, stroke, things like Guillain-Barré or different nerve injuries. Lymphedema management. Mary Freebed has a wonderful physical therapist over there in their outpatient clinics who does a fabulous job with our lymphedema patients. And then pelvic floor specialists as well. Occupational therapy. All right, before I get into this, so sometimes when I'm seeing patients and I'm describing what therapies we might do on inpatient rehab or what therapies they might need moving forward, they say, "What the heck is occupational therapy? I'm retired. I don't need to go back to work." And I say, "That's a good point, but occupational therapy really focuses on your daily activities, the things that you do day in and day out. Even retired can be your occupation." But what I like to describe to patients, and hopefully PTs and OTs who may be listening, please forgive me, but to simplify it for patients, this is how I like to describe it. Physical therapy is getting from point A to point B. Occupational therapy is what you do once you get there. So it's very simplified, but I think that kind of gives a little light bulb for patients to say, "Oh, okay, that kind of makes sense." But our occupational therapists do a wonderful job helping patients to be able to connect and do the activities that are important to them. All of your activities of daily living. So as I mentioned earlier, those are personal care tasks: eating, dressing, bathing, personal hygiene, toileting, continence management, knowing that I have to go to the bathroom and what do I need to do to make that happen, transfers for your ADLs and mobility with that. And then our IADLs, so instrumental activities of daily living. These get into more higher level cognitive thinking as well: transportation, finances, doing a grocery shop, meal prep, housekeeping, managing their medications and appointments. So a lot of coordination and executive functioning there. Speech therapy also helps us with that cognitive portion. They focus on patient communication, cognition, and swallowing. So a lot of people kind of equate speech therapy with the swallow because we see that most often in the inpatient setting. But their role is to help make recommendations. What is the least restrictive consistency of food and drink that still optimizes safety? And sometimes we see that patients are either too lethargic, too tired to safely trial swallowing, or they have discoordination in their swallow or weakness in their swallow from a stroke. We do also see some of the head and neck cancer patients who have difficulty swallowing because of tumor burden. But they work on exercises for articulation, vocal strength, breath support, as well as protecting our airway. So, cancer rehab specifically, it's not a new subspecialty, but it is an evolving subspecialty as we learn more about cancers and what are the functional needs of cancer patients. So, most cancer survivors experience acute symptoms during their cancer treatment. 70% of survivors will also experience persistent or late effects that can include pain, neuropathy, cognitive issues, incontinence, fatigue, and more. How often have you guys heard from a cancer patient, I'm just so tired all the time? Or chemo brain fog, right? And this functional decline is often identified as a primary cause of emotional distress for cancer survivors and their loved ones. So, how can we help? There's different rehab approaches: prehab, restorative, supportive, and palliative. And we'll get into those. So, I really like this slide here. It is a little busy, but it kind of has this, like it says, cancer survivorship continuum about prehab starts with diagnosis. And I actually see quite a few of these patients here in the hospital. Sometimes they'll come in with a new complaint. I actually just had a consult earlier this week. Patient had come in with a complaint of abdominal pain. It was persistent. They were having decreased appetite. They had weight loss, poor compliance or poor follow-up. They did not have a PCP, so they had not had any screenings for like the past 30 years. So come in with these symptoms and they get imaging and lab workup. There's a colon mass that's been identified. This gets biopsy. Patient has a new colorectal adenocarcinoma that has already metastasized to the liver. So brand new diagnosis, this hospitalization. He's not feeling his best because of weakness, just generalized debility. He's been getting around a little bit slower at home, needing some more help. So I'm consulted to see this patient to see, should we do some more therapies before going home? Can this patient go home safely? And if they do need therapies, where should those be delivered? Luckily for this gentleman, he's too functional for inpatient rehab, so we recommended some ongoing either home therapies. I always typically like to transition patients from the hospital to home with home therapies because I like them to have a home safety evaluation. Sometimes the environment, like I had mentioned earlier, the environment can sometimes create the handicap, right? Sometimes we just need a little bit of help, like grab bars, or let's do a shower chair so you can sit down while you're doing those bathing tasks so it's less fatiguing. You don't have to stand there and worry about your balance as much or worry about feeling lightheaded or dizzy while you're standing in the shower. Let's sit. Let's use a long-handled sponge so you don't have to bend over and so you can still reach everything you need to do while you're doing those self-care tasks. So how do we help adapt the environment to help our patients become more functionally independent? So for this gentleman, I recommended basically what we'll call prehab. I recommended that he do some home therapies and then transition to outpatient to hopefully build some strength and endurance. In the time between his diagnosis, he'll be getting an outpatient PET scan for further characterization of what's the extent of his disease and then potential treatment that he might undergo. So this gives us a little bit of time to hopefully be able to build some of that strength and endurance so he can tolerate cancer treatment hopefully a little bit better. And then restorative rehab can happen during the treatment process, maintaining the function that we have. So hopefully we don't have as much of a functional decline through cancer treatment. And then we also have supportive and palliative. So this is just another slide kind of talking about prehab and that kind of a restorative rehab through treatment and after treatment. So prehab, let's think of our patient that I had earlier this week. You know, I'm recommending some prehabilitation therapies for him. So hopefully, now that he's had his diagnosis, he'll be able to do some therapies, build strength and endurance. And then when he does undergo acute treatment, we know we might get a decline. It's really taxing on the body, but hopefully, if he does have that decline, it's not going to put him below where he was at when he was first diagnosed. So it kind of gives us, let's say, like a little bit of a buffer zone, being able to do that prehabilitation and work with therapies to say what's the best way for me to maintain the function that I do have as I'm going through treatment. So restorative cancer rehab. The aim is to return patients to their pre-treatment level of physical, psychological, social, and occupational functioning. So just to go back a little bit, that's kind of when we've had this dip down, we need to do rehab again to try and get back to where we were before. So that often takes place during cancer treatment. And it's typically when short-term functional impairments are anticipated, but not long-term impairments. So post-operative range of motion exercises for patients after a mastectomy to make sure that chest wall is moving okay, that we're not getting any radiation fibrosis, or we're working through that, okay? Because we need good range of motion in order to do our activities, daily living, right? Dressing and bathing. Think about trying to brush your hair without having that good range of motion in your shoulder. Kind of hard to do. Putting on a shirt, you know, some of these just daily things that we're like, oh, I never realized really how many steps it is to do these daily tasks and how challenging that might be if I'm dealing with a cancer diagnosis or neurologic injury after a stroke or a spinal cord injury. Supportive. This aims to maintain current function. This is something that I often recommend for patients to continue with outpatient therapies. And I will put that when I'm putting in an order for outpatient physical and occupational therapies, I will put maintain, you know, and work on gait, balance, transfers, fall prevention, and fall recovery. How do we get up off the ground if we find ourselves there? And they also do a really wonderful job at recommending different DME or durable medical equipment. Those are things like straight canes and how do you use the straight cane properly. Walkers, different kinds of walkers, a two-wheeled walker versus a four-wheel walker, which is the safest one for their particular needs. Wheelchairs, do we need a ramp? Do we need the shower chair, extended tub bench? There's lots of different kinds of equipment out there to help patients be able to be more independent with the functional tasks. One thing that comes to mind is sometimes you'll see a commercial for a gadget and you're like, who needs that? Everybody can open a jar. Well, not everybody can. And sometimes accessibility with a gadget that can help you open up a jar can give you a little bit of independence, right? You're not stressing your joints, or it's easier if you've got a little bit of hand weakness. So if you see a little doodad or a gadget and think, who would need this? It's probably not for you, but somebody with a functional impairment might go, oh my gosh, that would be so great to have. Again, optimizing our environment so we can be as functionally independent as possible. and improve our quality of life, right? Everyone wants to maintain a certain level of independence. We hear that over and over again. All right, palliative rehab. So, while the goal of conventional rehab is restoring function, right? That's what my role in the hospital here is helping to identify patients who have a functional deficit and have a reasonable um, trajectory to be able to make functional gains in a short period of time with intense therapies. That's my role. But sometimes we're looking at maintaining. So, palliative rehab focuses on quality of life, symptom control, and self care independence. We're optimizing that mobility and activity levels, like we've been saying throughout. All right. So this here is a nice little slide talking about what rehab palliative care is and what it's not. So rehab and palliative care really they go together so well. They're really not a clash. Sometimes we'll see patients and think, "Oh man, there's no way that they could do some therapies. There's no way that patient is getting home." People will sometimes surprise you, but then also sometimes people got to fail rehab to realize that, you know what, I am needing more help and I am going to need some more help at home. And maybe doing further interventions in the hospital is not what I want for my goals of care. I've had a couple in my very short time as an attending where they'll come to inpatient rehab and realize, you know what, I just really want to be home and enjoy the time that I have left. So I actually have a patient right now who we're going to be doing our hospice informational is they're gonna come in and chat with patient and family a little bit more about his current condition and how we can support him moving forward and get him home. So it's definitely not uncommon for me to come on and be consulted for a rehab purpose, and then I'll end up following from a palliative perspective. So I'm grateful for my fellowship training every day. So again, palliative and rehab care and how they go together. Um, our our aim is to help our patients and their caregivers optimize that function, well-being, enabling them to live as independently and as fully as possible. So very synergistic. We both have the same goals for our patients. We just come from a different perspective. So I told you we'd talk about exercise. So here we are, exercise and fatigue. So cancer-related fatigue, this definition here, it's a distressing, persistent, subjective sense of physical, emotional, or cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity, interferes with usual functioning, and is not relieved with rest. Some people will describe, again, like that chemo brain. They're just so tired all the time. It's harder for them to think through normal tasks, or they're like bone deep tiredness. Man, if my house was burning down and I was sitting on the couch, I don't know if I would have the energy to get up and get out of the house. It's that like soul weariness almost at times. So, why does fatigue occur? Lots of different reasons, right? Disturbances in our sleep, dysregulation at a hormone level, deviations in CNS serotonergic regulation. So, um, just as a side note, after a stroke, sometimes we'll see what we call neurofatigue, right? The brain is going through a lot and healing, and it's tiring. Um, Elevated levels of inflammatory cytokines, anxiety, depression, and history of fatigue prior to cancer, right? If we've got that history already, and then we add a cancer diagnosis and treatment and all of the like psychosocial as well as physical stress of going through that, it's a burden. All right. So, a little bit about kind of bed rest. Immobilization decreases strength by about 1.5% per day. So our patients who might be on bed rest in the hospital, they get weak just over the course of being here. Strength can decrease as much as 20 to 30% during a 7 to 10 day of bed rest. So again, think of some of our patients who are in the hospital. They're not allowed to get up on their own because they're a fall risk. We know that our nursing staff has challenges with their staffing ratios. We never seem to have enough nurses aides to help them out. So patients can sometimes feel stuck. They feel stuck in their hospital bed. Sometimes they're in a two-person patient room and there's no room for a bedside chair. So they're really, you know, just immobile and they're feeling not their best on top of it. So yeah, that strength can definitely decrease just over the course of a hospitalization. Um, so lack of stress and tension on bone via weight bearing can lead to osteopenia. This is more a little bit long term effect. Joints with decrease in connective tissue extensibility and articular cartilage begins to deteriorate. We get skin atrophy and risk for pressure injury. And that, along with risks to skin and pressure injury, it takes about 2 hours of a, let's say, static position. That 2 hour interval, skin will start to break down. So that's why you will often see nursing communication orders for Q2 turns to help with pressure relief. And it just has to do with skin connective tissue, blood flow, nutrient delivery, and how immobility and staying on a particular spot can be dangerous for skin integrity. Um, Redistribution of body fluid can lead to postural hypotension as we lay down and we're in a supine position. We get redistribution of fluid. This is also why after laying down, sometimes patients will have like a half hour later, they're like, oh, I have to get up and go to the bathroom. It's because we had some fluid redistribution. But a lot of our older adults or patients with some type of neurologic injury, think of some of our diabetics with really bad peripheral neuropathy, can also have autonomic neuropathy, or Parkinson's patients can have autonomic neuropathy. And I know I'm talking about a lot of neuro things, and gosh, Dr. Phillips, I hope I'm doing a good job describing some of these things. But that peripheral neuropathy or autonomic neuropathy can lead to postural hypotension as well. So exercise can help us address some of these things or mitigate the harm that immobility can cause. Oh, and here at the bottom, urinary stasis can lead to UTI and decreased GI motility, leading to constipation. So patients who are constipated, we get them on a bowel program and we get them up and moving. All right, timeout. If we're already so fatigued, how is trying to do more or do exercise going to help? Understandable. That's why we have to find a balance between rest and activity. It's kind of one of those, what is it, the uh, physical law of inertia, something in motion stays in motion, it's something at rest stays at rest. So we got to find that balance. Like, we don't have to run a marathon, but maybe being able to get up and get to the chair and get to the chair, from the chair to your bathroom, getting bathroom to back and doing household tasks. Like, again, the goal is functional independence as much as we can. So there's lots of cancer guidelines encouraging at least some level of physical activity. And then doing aerobic activity and resistance exercises can help improve bone health, cancer-related fatigue, sleep difficulty, anxiety, depression, and health-related quality of life. So again, I said there was going to be a lot of these kind of screenshots of guidelines, but again, here's guidelines on physical activity from the National Comprehensive Cancer Network. Here's another one about different examples of physical activity, everything from light exercise to vigorous exercise. And then here's a nice little handout on moving through cancer. just different things here about addressing function and quality of life. How does exercise help? And we've kind of already talked about a lot of these. This last one here is the one that I think could be really helpful. This is from American College of Sports Medicine, and this is their Exercise is Medicine handout that I think can be really helpful to give to patients on aerobic activity, resistance activity, or a combination of those things. So this is kind of for our own edification on how doing activities can help with all these different symptoms: cancer-related fatigue, health-related quality of life, physical function, anxiety, depression, and lymphedema. Oh, okay, that is my last slide. I wasn't sure if it was or not. So we've got some time for questions. Let me stop sharing my screen unless somebody wants me to go back to a certain slide. But thank you guys for listening to my little chat here, and I'm happy to answer any questions you guys have about rehab, the role of physiatrists, how we can help, or how rehab and palliative goes together. Okay. All
I
right.
want to talk a little bit about, can some of these elements be integrated into hospice as well?
Mhm.
Because typically with hospice, the functional status isn't great, but I've definitely come across patients who do value having at least some degree of mobility even at the end of life. So is that something to consider or something that's even possible?
I think part of the limitations that we have with that is just in insurance coverage, right? Insurance sees somebody in a hospice and they go, I'm sorry, you want to do therapies with this patient? No. So, something that I might recommend when we're looking at somebody coming onto hospice or somebody who is already on hospice, do we need to adjust to the environment? So I would be looking at a home safety evaluation. This would probably be a one or two time um, visit from home therapies just for the adjustment of the environment. But also, our hospice nursing staff does a really great job with this as well, because they're the ones who kind of come in and can sometimes be the ones delivering some of those activities of daily living, like helping patients with showering or helping families learn how to do tasks for patients. But that's the angle that I would go at, is we're doing caregiver training. What's the safest way for caregivers to help deliver care to their loved one on hospice? What's the safest way to do turns? What's the safest way to do toileting tasks? How do we dress a patient safely? How do we help transfer them? So caregiver training, that's normally what I'm looking at. And if I'm bringing someone to inpatient rehab who maybe is a low functional level, right, needing a lot of assistance, um, but their goal is getting home. Their goal is getting home, and they're going to sign on with hospice once they get home, but they're just needing so much more help. But family is motivated. They're going to be there for support. They want to take care of their loved one, but they just don't know how to do that just yet. Sometimes I will advocate to try and bring that patient over with a medical debility with the goal of doing caregiver training and getting that patient home. I don't always win those insurance fights, but I try.
Speaking of insurance fights, I really love the idea of prehab. Uh, is that easy to get approved? And if not, do you have any tips or tricks?
So, outpatient, I think, is probably a little bit easier. Inpatient, it's tough. So, for a patient to qualify for inpatient rehab, they have to have a certain level of medical need, either a rehab diagnosis or a medical complexity that necessitates being seen by a physician at least 3 days a week. They also have a certain need to have a certain level of therapy needs. One thing that I didn't include, and I really wish I should have, but I think when I was making this presentation, I was like, oh, that's common knowledge, but it's kind of not. Like, what are the different levels of assistance needed? So you might see things like supervision or setup. Sometimes patients can do their self-care tasks, but they need a little help setting things up, whether it's because they've got peripheral neuropathy or weakness in their hands and they can't open up food packages. They can feed themselves, but they can't get the package open. Again, what is our jar opener helper, right? Some of those little adaptive equipment. Sometimes patients will need what's called standby assist. They can do the task, but we need somebody there to help just in case there's a loss of balance or for safety cues. For some of our stroke patients with like a neglect or a hemianopsia, they're not paying attention to one side of their body or they literally can't see it. So just cues for safety. Let's scan for our environment, make sure we're not tripping over anything. So that's standby assist. Contact guard is maybe just a hand on a gate belt, but they're doing okay. Minimum assist is the caregiver assists with less than 25% of the task. So maybe just a little bit of help with that initial like sit to stand or a little bit of steadying as we're moving through a motion for a transfer. Moderate assist is kind of in that 25 to 75% of help from a caregiver doing a task. And then maximum assist is at 75 plus. Total assist is that the patient's not able to participate at all with the task at hand. So hopefully that helps kind of with some of the things that you might see from our therapy friends, our colleagues in therapies who are saying like, oh, this is how the patient did with these individual tasks. You'll see things like supine to sit, sit to stand, stand to sit, bed to chair transfers in the hospital, mobility. So how far are they able to ambulate? Are we progressing to do stairs? Those sort of things. Is that helpful?
Yes.
I feel like I didn't answer the question that you asked, which was about rehab. You got a little bit more than you bargained for.
No, it was still helpful.
So if I'm looking at somebody coming to inpatient rehab for prehab, again, they have to have been hospitalized for one. So I'm seeing them as a consult in the hospital. And a lot of times I'm looking at, okay, how can I argue this medical complexity to an insurance company? Because they don't want to pay for anything inpatient. So a lot of times they'll say, oh, this patient doesn't need to be seen by a physiatrist. So I'm looking at things like, okay, again, fatigue. Do we have any bowel or bladder problems? Are we dealing with any psych issues? Because physiatrists can help with that as well. We're directing, so it's medically supervised therapies. Do I think there's anything specific going on that necessitates a physiatrist needing to see that patient inpatient? Or are we saying, okay, patient is at a certain level, maybe they're a little bit of min-assist, but they're doing mostly standby assist or supervision, so they'd be safe to return home and do outpatient therapies. And I will put those recommendations at the bottom of my note with my plan that this patient should do outpatient therapies to help maintain function and improve endurance prior to therapy treatment, and then ongoing maintenance of function. Most people who are writing a PT or OT script go eval and treat. We can be a little bit more detailed, and that helps. Like, what do we want this patient to do? You know, like, are you sending them for ortho issues? Because your patient's not going to know. They're like, I don't know, my doctor sent me here. They're probably going to bring up back pain they've had for the past 25 years. Not like, oh yeah, I'm going to undergo cancer treatment and they want me to build my cardiorespiratory endurance before I do that. Like, they're not gonna know. Or sometimes too, if I've got a patient who comes in, this is kind of just more general. If I've got a patient who's like, oh yeah, I've had so many falls, more than normal, I'm like, ma'am, the amount of falls that are normal is 0. we need to work on this, and then identify what's the problem. Do they have a neuropathy where it's harder for them to feel where they are in space? Is my patient furniture surfing, right? Oh, I don't use a cane or a walker, but they're really holding on to the wall or looking for that. What's that next level of support? Because that tactile kind of input, think the distance from your hand to your brain is shorter from than from your foot to your brain. So having that additional tactile is actually helpful for proprioception. So that's why things like a cane or a walker might be really helpful for patients with neuropathy to help with the stability. I feel like I'm getting off topic, but if a patient has lots of falls, I might put in my therapy script, I want this patient to work on ambulation, balance, fall prevention. So, how do they correct a loss of balance while they're standing? And then fall recovery. If they find themselves on the ground, how do they get back up? I see a lot of patients come in with general debility who ended up on the floor and they couldn't get back up. So, they had to call EMS for a lift assist. So knowing how to get up off the floor can also be helpful. We don't want them there in the first place, but I love when patients will tell, oh, well, I didn't fall. I just kind of like slid or like, I'm like, did you plan to be there before this incident started to occur? If not, then it's a fall.
And I do like sometimes, Kara, my patients will come in and tell me they were taught how to fall. So once they're going, they'll tuck and roll.
Yeah.
Or whatever it is that you guys teach them. But yeah,
Minimize damage, right?
Exactly.
One day it was a busy day of consults and I had so many patients. And I swear, like 80% of them were little old ladies who had had a fall and a right hip fracture specifically. I had to do my notes as I went along because I'm like, I'm not going to be able to remember which little old lady with a right hip fracture this was. I was like, which way was the wind blowing that weekend? Like,
They were all wearing stripes.
Yeah.
Little gold slippers.
Oh, yeah.
Always.
Yeah.
I'm like, get some sneakers, man.
The professions that you practice, Kara, do mesh nicely. Is it? I mean, I hope McLaren's making it somewhat easy for you to meld them. Are they, or do you have to kind of like wear two hats, or is it one big hat, or?
that's a good question. So I am kind of directing that a little bit. Like I'm credentialed as a physiatrist. This is my role here. Like I said, I get consulted on all the stroke alerts that come into the hospital. We are a comprehensive stroke center, so they do, we do the TNK, they have the mechanical thrombectomy, we've got a neurosurgery team on staff, so we craniectomies, they can do brain biopsies, etc. So we see a lot of different kinds of patients in our neuro ICU. So sometimes I'm getting a consult for somebody with acute stroke, whether that be hemorrhagic or ischemic. And I'm seeing them very early on in their course. Maybe we're dealing with a lot of neurofatigue. Maybe they're still intubated. So I'm able to use my palliative training to help families navigate that initial portion, right? While we're hopefully waiting for patient to become more alert, be able to do their spontaneous awakening and breathing trials, hopefully get off of ventilation, and then start to work with therapies. How are we doing with the swallow? Do we still need the NG tube? If they're not able to progress for whatever reason, are we talking further interventions like a PEG? And so I get to, in my little my phrase at the end of my consults, I'll be like, PM&R will follow for evolving rehab needs, comma, and palliative support. And we've got a list for the hospital. Our admissions liaisons on the inpatient side of things help me out with this. And we've got a list of patients that we're following, patients from our hospital, patients that we might be reviewing from out of hospital. And so they've developed a separate section of the list for me for palliative follows. So maybe I'll see a patient in neuro ICU. They've got a really bad brain bleed. It's extensive. It's involving brain stem. They're still intubated, not sedated, unresponsive. We know this isn't going to go well, right? And the family's going to need some support through this. So I will say, patient is not an IPR candidate. However, physiatry will follow for additional palliative support. And so I do. And so they're specifically on my list to follow up on. I do also have a nurse practitioner who helped me out with follow-ups. But I see all the ones who are more palliative. Mhm. And
The
actually,
foot in the door, getting in there and infiltrating.
and I think it's been really helpful. It's been really well received by staff down in neuro ICU. And actually, I have a really good, well, I say really good story as anyway. So a patient comes in, they're from the northern region, and they get transferred down to our facility because, again, we are a comprehensive stroke center, and we're one of the closest ones for some of those upper lower peninsula patients will get transferred to our facility. So patient had had a pretty significant intraparenchymal hemorrhage. They did get an EVD, so drain to help with decompression there, but they had a significant amount of cerebral swelling. They had additional bleed and additional ischemic strokes as well during the course of their neuro ICU stay. He had been able to become extubated, work a bit with therapies, but he was maxed to total assist, having difficulty with commands, and then he had another stroke. This was a young guy in his late 50s. So I stayed on, okay, maybe we're getting some alertness and working with therapies, but we're needing a significant amount of assist. So trying to see and follow along what kind of therapy needs are we going to have and what level of post-acute therapies or like what's the next step. So following along with how are we progressing with therapies, are we going to be able to transition to the next level of care? But then with additional complications, he wasn't able to protect his airway and he mucus plugged and needed to be intubated again. Like this poor gentleman really went through it, and family was having a very hard time. Spouse had that engineering brain, right? If I can just organize it well enough, everything's going to be okay. So I had a really hard time going through this, but seeing them on their initial arrival, and then as we're going through all of these setbacks and his changes in function and additional neurologic decline, being able to have had that rapport with family at bedside and follow along with how is this going?
Yes.
We got to a point where he was intubated again, and cerebral edema was worse. He had additional strokes, and he started to herniate. Patient was on the gift of life registry, so they had come in and were going to talk with patient's family, but the spouse had a really hard time with that. She wanted him home, which was up in Petoskey. We're in Flint. She was adamant she wants him home. And so we reached out to our hospice liaison, and I tell you what, I didn't think we were going to be able to do it. I was like, it'd be unlikely for them to transfer a patient who is still intubated that amount of distance, right? However, whatever network she had, she was able to help coordinate transportation for this patient to be able to go home, be extubated at home, and sign on with hospice. I tell you what, I cried tears of joy. Obviously not the outcome you would want for a 58-year-old gentleman who was working, construction, robust, otherwise healthy. Well, except for his hypertension, right? And having this big stroke. But to be able to help this family navigate and say, yes, I understand you want him home. I don't know what we're going to be able to do, but all we can do is ask and see. And they were like, okay, let's do that and see. They were understanding that we might not be able to do that transfer, but they wanted us to try and look into that and see if it could be done. And so the coordination between the medicine team down in neuro ICU, between our hospice liaison and the hospice agency that they ended up going with in the Petoskey region, like that level of coordination of care, and it was just fantastic to see. Like obviously, not the health outcome you would want for a young gentleman like that, but to help alleviate some of that like emotional suffering that the family was going through to help get that patient home, it was just incredible. So yes, again, I'm grateful for my hospice and palliative fellowship training every day because we do see those patients.
Yeah, that's great. Keep doing the good work you're doing.
Doing what's best, right? That's sort of like the McLaren tagline.
Well, I think you're definitely highlighting the role of primary palliative care in that rehab is in that role of improving quality of life. But thank you for taking it that step further and
Mhm.
getting your rehab service into specialty palliative care.
Yeah, and I actually just did a talk for the physical medicine and rehab residents in the Lansing residency about stroke and prognosis and how they should be doing primary palliative care. We're seeing patients their initial hospitalization after a major life-changing neurologic event. We do palliative care. Like it was well received. So
That's good.
any other questions, you guys?
Well, thank you again, Kara, for coming in and sharing with us. I think we all learned something more today. Um, and yeah, like she said, we'll get the video up online, but I'm sure you're open to any questions as they come along the way as people read the video. But thanks again.
All right, you guys.
Thanks to see you.
Too.
Yeah, thank you.
Take care.